So I have 11:02 my local time. So what I want to do is just get started. I'm sure a couple folks will join us. So again, welcome everyone. We're very excited to be here today to celebrate National Native HIV/AIDS Awareness Day. The theme is Zero is Possible Together, Innovation plus Awareness. So before we get started, I'm going to pass it over to our colleagues who are collaborating with us on this exciting event.
Thanks so much, Michelle. Hi, everyone. My name is Elena Rosenberg Carlson, and I'm the Ending the HIV Epidemic Coordinator here at the UCLA Center for HIV Identification, Prevention, and Treatment Services, or CHIPTS. And CHIPTS has been working to help facilitate a regional response to the HIV epidemic across our 8 EHE Phase 1 counties in California. And a really critical part of that effort is ensuring that we're engaging and addressing the needs of all communities disproportionately impacted by the epidemic. So we've had the opportunity to partner with PACE on a couple of community engagement panels as part of our EHE Regional Learning Collaborative. And we're just really delighted to co-host today's event on this critical topic of eliminating HIV disparities and inequities in Native communities. So March 20th was National Native HIV/AIDS Awareness Day, which is observed to recognize the impact of HIV among Native populations and to highlight the work happening in communities around the country to engage Native people, including American Indians, Alaskan Natives, and Native Hawaiians in fully ending the HIV epidemic. So in honor of National Native HIV/AIDS Awareness Day, and in support of the ongoing work needed to address the HIV epidemic in Native communities, this session will focus on how HIV/AIDS disproportionately affects Native communities, on understanding the challenges and barriers to HIV/AIDS testing, linkage to care and prevention among Native communities, and on best practices for working with tribal nations to eliminate HIV disparities and inequities among Native communities. Next slide, please. So before we get started, we just wanted to go over a couple of quick housekeeping items. So first, this session is being recorded and will be made publicly available. Please be sure to keep your line muted if you're not speaking to avoid any background noise during the session. We do plan to have a few opportunities for Q&A during the session. So please enter your questions at any time during the session using the Q&A function on your Zoom control panel. And if you'd like to share any comments or relevant resources during the webinar, or if you have any technical difficulties, please use the chat function. And then after the session, please look out for an email with a link to a brief evaluation form and relevant resources from the session. Please do complete the evaluation. It's just going to take a couple of minutes, and we will really use all the feedback we receive to inform future sessions. Next slide, please.
Great. Thanks so much, Elena, for that. Thank you. Thank you for that introduction. And we are always very excited to collaborate with UCLA HIV Center, the work that you're all doing, not only regionally, but across the region and nationally. So what I want to do is just take 2 minutes to just share some of the things that we're doing within the Office of Infectious Disease and HIV and AIDS policy that are really focused around addressing some of those inequalities that we'll be hearing from our esteemed panelists and what we are doing not only regionally, but nationally. Our community engagement efforts have really been focused on communities that are hardly reached, right? We have and we continue to engage with Native and organizations and leaders that serve Native communities, really to be able to inform what we're doing not only at the local level, but at the national level. So we have created and developed some good partnerships with Native serving organizations, and you'll hear from some today. The HIV National Strategic Plan released in January of this year designates American Indian and Alaska Native, gay, bisexual, two-spirit, and other men who have sex with men as one of its priorities. I encourage all of you to review the plan on hiv.gov and really use it as a way to consider how your community, your organization, your clinic can really align their activities with the vision, goals, and the objectives of the plan to be able to address the inequalities that not only our Native community face, but many communities of colors. And the national data for the 5 of the 6 Ending the HIV Epidemic Initiative, which we're all very familiar with, the EHE. These are indicators that are presented on America's HIV Epidemic Analysis Dashboard, which you often heard me say the AHEAD dashboard. And this really allows jurisdictions to visualize the data, but it also serves as a way to be able to measure our progress towards ending the epidemic among our Native communities. So that's very excited that we have data that shows us transparent to our communities on our efforts. Then our Minority HIV/AIDS Fund has funded projects through Indian Health Service to be able to strengthen the infrastructure, support universal HIV screening, and increase PrEP and address some of the stigma. And we'll be hearing some of those projects that have been implemented. And then finally, I'm excited that the mail order prescription fulfillment option that's now available through the HHS Ready Set PrEP program, which is a program that provides free PrEP at no cost to those without medication coverage, really allows healthcare providers at Indian Health Service, tribal and urban Indian clinics to provide free medications by mail. So now individuals don't have to worry about transportation or going to a pharmacy. They can now get that prescription directly to their home, to a PO box number, or to the facility. So this is very excited because we know with issues around access, transportation, and location is always an issue. So just wanted to provide just a taste of some of the things that we're working and how committed we are, not only regional, but nationally, to work with our partners to end HIV inequalities among our Native community. So now to the best part of our session. So you don't have to hear me all the time. I wanted to just take the moment to highlight the exciting agenda we have today. For the first 30 minutes of our session, we're going to hear from 3 leaders nationally, talk about some of the work that's being done nationally, provide recommendations. You know, how do we begin to work with Native communities, tribal communities to start addressing those inequalities as non-Native public health practitioners? And then we'll hear from 3 esteemed panelists who will be joining the conversation at the end, do some introductions about some of the work they're doing in their organization. And then the rest of the session will be focused around a discussion, you know, a very informal discussion, hearing from their experience on what are some recommendations we can do to continue the momentum in ending HIV inequality. So with that said, I'd like to introduce our first speaker today, Rick Haverkay, who is a National HIV Program Director with Indian Health Service.
Great, thanks, Michelle. I appreciate the time, and thanks to all the folks who took the time to put this together, and for our co-panelists, and thanks for you for tuning in and helping us spread the word about the good work that's being done. I wanted to share with you, starting off, some of the data that we found around HIV. First of all, I do use he, him pronouns. I'm an enrolled member of the Sault Ste. Marie tribe of Chippewa Indians. That's in northern Michigan. I've been with Indian Health Service about 6 years now. Before that, I was with the Office of Minority Health, National Indian Health Board, and Intertribal Council of Michigan. This brief update I'm going to give today is based on the latest available HIV statistics for American Indians and Alaska Natives. So we're using data from the Centers for Disease Control and Prevention that was reported through December 2019. And it also includes, but it's not limited to, data from the Indian Health Service. And a little caveat there, it's important for folks to know that just because you have American Indian, Alaska Native data doesn't mean it's for everyone in the country. There are so many different databases. If you're seen at a federally operated Indian Health Service clinic, I'm pretty good and comfortable knowing that data. But if it's coming from a variety of sources like state health departments, private insurers, then some of that data could be miscoded for race and ethnicity. In fact, some of our studies show up to a 50% misclassification for American Indians and Alaska Natives. And tribal data and urban Indian healthcare data is yet another layer of data. We're working with sovereign entities. They don't have to share their data with anyone. It's their data to use it as they see fit. So there's no law requiring tribal or urban health facilities to share their data with me at Indian Health Service. So when I talk about the data today, it's data that's been shared with the Centers for Disease Control, just to make sure that you don't think it's for every single American, Indian, Alaskan Native in the country. We're pretty good with thinking that it's pretty representative, but keep that with a grain of salt. Like all health system providers, IHS facilities report notifiable diseases to their respective health authorities, which in turn transmit the data to the CDC. The link to the CDC's annually published surveillance data report is at the bottom of the slide on the screen. If people want, I can put that into the chat box later on. Next slide, please, Michelle. This figure is taken directly from the National CDC report and shows trends of new HIV diagnoses by race and ethnicity. The slide includes a subset of racial groups with lower rates of new diagnoses, which explains why this graph does not include all races and ethnic groups in the US. It's a piece of that data. The full data set can be found back at that CDC link on the previous slide. Yep, we're still on the first slide. Although there's a slight US rates of HIV diagnosis. There you go, that one. Although there is a slight variation from year to year, the new HIV diagnosis trend from 2014 to 2018 is considered fairly stable. So we've seen a little bit of a plateau or stabilization of our new HIV rates. The HIV diagnosis rate is approximately 8 per 100,000 for American Indian Alaska Natives compared to 5 per 100,000 for whites. Next slide, please. In that same CDC report, the death rate among American Indian Alaskan people living with HIV in 2018 was 30% lower than it was in 2014. Some good news for a change, right? That the rate was 30% lower in 2018 as compared to 2014. We can't really infer any specific causes on a national scale, but we do know that the larger IHS operated HIV treatment programs like the ones at the Phoenix and Gallup Indian Medical Centers show outstanding HIV testing, linkage to care, and viral suppression outcomes among their HIV patients. Next slide. This slide looks at the HIV transmission mechanisms among AIAN men in 2018. 84% of the reported HIV diagnosis in AIN people were among men. Most of the documented HIV transmission among these men was from male to male sexual contact, which accounted for 75% of new diagnoses. The second most common transmission route was from injection drug use combined with male to male sexual contact, which accounted for 15% of new diagnoses. Next slide. Among AIAN women, the main transmission route was heterosexual contact, accounting for 57% of new diagnoses, followed by injection drug use at 43% for new diagnoses. Next slide, please. We have seen significant progress around Indian country towards ending the HIV epidemic goals. HIV projects and activities are supported by the Minority HIV/AIDS Fund, which covers 100% of the work that IHS has been doing to this point around HIV programming. We're incredibly grateful to the Office of Infectious Disease and HIV/AIDS Policy for supporting our funds. IHS has to compete. We don't get any funds, just sort of, here you go. It's all competitive funding that I apply for every year. And this past year, we successfully competed for about $8.3 million. And that fund is spread across Indian country to those areas of greatest need. The true heart and soul of the Minority HIV/AIDS Fund is to get funds to those areas with the greatest need. But part of the funds that we got this year went towards tribal epidemiology centers. In fact, $2.4 million in cooperative agreements were sent out to 9 of our 12 tribal epidemiology centers. 3 of the 12 didn't apply. So all 9 that applied did receive funding. And I'll tell you just a little bit of the work they're doing. The Albuquerque Area Southwest Tribal Epidemiology Center developed an HIV/AIDS resource guide for the 27 tribal communities in New Mexico and Southwestern Colorado. The guide contains data on HIV, hepatitis C, and other sexually transmitted infections in the geographic regions, and highlights area resources in the communities that provide HIV testing and PrEP. The Alaskan Native Epidemiology Center executed the Global Network of People Living with HIV Stigma Index survey in Alaska Native communities. That's a mouthful, right? But it's a survey to look at people living with HIV and the stigma they feel. So we'll get a better idea on how that stigma is affecting our folks in Alaska. The Urban Indian Health Institute's Tribal Epidemiology Center created a survey on HIV and PrEP knowledge, attitudes, and beliefs for staff at 41 urban Indian health organizations. Little piece of info there, lots of tribal programs in the country, 576, I think, and counting, federally recognized tribes. We also have urban programs around the country. There's 41 of them, and nearly all of our major urban centers in the US have an urban Indian health organization. The Oklahoma Area Tribal Epidemiology Center, better known as OK Tech, in coordination with the Northwest Portland Area Indian Health Board, launched a campaign to train providers and increase access to PrEP prescribers. The effort now counts for more than 50 providers and represents 34 different tribes and tribal facilities. The OK Tech and the Cherokee Nation are increasing HIV testing through a text messaging system, which is already in place and operational. This text messaging system will deliver HIV self-testing kits to doorsteps throughout Indian country. OK Tech has a goal of a statewide reach by 2021 and a national outreach program by 2022. And the Northwest Tribal Epicenter is using race-corrected HIV data from the Washington State Department of Health to better understand the HIV disease burden within Northwest tribal communities. The Northwest Portland will use these data along with virtual and in-person training on prevention, control, and outbreak investigation to adopt new HIV prevention and control methods on a local level that are destigmatizing and culturally appropriate. Next slide. I'll give you a few other quick updates. In August, the IHS leadership approved the new Indian Health Service HIV primary care treatment recommendations for adults. You can go to ihs.gov, and just search HIV treatment, and you'll be able to find that new document. The IHS National HIV/HCV program continually searches for ways to help our area offices and service units achieve their HIV and hepatitis C goals. And in the summer of 2020, the IHS National Program created IHS area-wide and service unit-specific report cards for nationally monitored HIV and HCV screening measures. So if any folks on this webinar are working for an area office or a service unit, you know how tedious it is for us to constantly collect data. And it's so important, but I think what rarely happens is you get those report cards back, letting you know how well you did compared to the rest of the folks in your area or the country. So we provided those report cards last year so folks can see. And we've got some real winners. We've got some tribes, some service units that are getting to the 90% mark of testing their patients for HIV, and getting up in the 70% mark for screening their patients for hepatitis C. So incredible work going on. And a lot of that is because of the funding we get from the Minority HIV/AIDS Fund. In August, IHS, in partnership with the Northwest Portland Area Indian Health Board, released the fourth and final course in a learning module called PrEP Navigator Training for community and public health staff. And this learning module is available online. It's free, it's self-paced. You can start and stop anytime you'd like. There's 4 courses. Each one is maybe 30 minutes long. But go to ihs.gov and search PrEP Navigator. ihs.gov and then search PrEP Navigator. The Northwest Portland Area Indian Health Board's Healthy Native Youth Collaborative launched a Talking is Power campaign to help American Indian Alaskan Native parents and caring adults initiate difficult conversations about sexual health topics with their teens and young adults. And you can join in on that by texting the word EMPOWER to 97779, EMPOWER to 97779. Northwest Portland recently began its second cohort of a 6-month trans and gender affirming care, ECHO, which is designed for IHS tribal and urban Indian healthcare providers. So we're really working hard to make sure we include training for our providers so they can best meet the needs of our trans and gender nonconforming users of IHS facilities. To assess the impact of COVID-19 on our IHS services specific to HIV, we did a 3-question survey 3 different times last year to our top performing HIV care facilities. And we found that overall patient health care has had little impact due to COVID, and our antiretroviral therapy is going as desired, as planned. However, many providers signal that the quality of care is suffering and the effects will be made evident over time. Because of a lack of in-person visits, some clinical indicators might go undetected. So we're working very hard to make sure that we're utilizing all the tools available to us through things like telehealth. But COVID is causing these HIV medical teams to work in silos more than ever before. And at least one of our sites has reported new HIV patients since COVID-19 started. Still, one facility noted that resources going towards COVID-19 had actually improved adherence for antiretroviral therapy, that therapy that gets folks to that undetectable viral load. Little plug here for treatment as prevention. If we get folks who are living with HIV into care, get them on the medicines they need, keep them there, and we can get them to an undetectable viral load, that person is virtually incapable of passing HIV. So because of some of the COVID funding, we were able to actually improve some of that ART. And there's a portion of this one clinic's HIV patient cohort that were homeless, but emergency housing was made available as part of the COVID-19 response, helped stabilize their housing situation, helped get them to the undetectable viral load. So, I guess we have to look for the silver linings when we can. PrEP services actually are struggling to adapt. The intake and quarterly laboratory visits require in-person visits that are more complicated, as you can imagine, while health facilities adjust to essential in-person visits only. Thankfully, there's some light here at the end of this tunnel. But the demands on laboratory resources for COVID-19 support is very high. Our labs are really seeing a lot more work than they were used to with COVID, so it's harder to get appointments in for those folks on PrEP. But we're on discussions with those in the field on when and how to best approach scaling up our PrEP services. And I want to thank you for allowing IHS and me to present on this EHE update. If you have any programming questions, please get a hold of me at the email listed on the screen. I look forward to answering any questions folks might have. Thanks, Michelle.
Thank you, Rick. I think you set a really nice stage highlighting those inequalities that our Native community faces and what IHS is doing. So with that, I'd like to introduce our next speaker, Michael Allison. Michael Allison is a Native American liaison for the Arizona Department of Health Services. And he'll be talking about, now that we've seen the data and we know some of the work being done, how do we begin to work with tribal nations? So Michael, with that, I'll turn the floor over to you.
Okay, thank you, Michelle. Can you hear me okay?
Yes.
Okay, good. Rick, excellent presentation. Good to see all the work that Indian Health Service is doing. So I am Navajo, and in our language, we call ourselves Dana. And so I'm going to introduce myself in Navajo. Yata Kwasana, Shay, Michael Allison in Ishya, Jose Tachinishna, Nakadna Basichin, Dasha Chema Dashkishni, Dasha Nale Sanajini. I see not ani nezda nasha. So those are my clans. I know in every group there's always Navajo people, and so we by tradition we introduce ourselves by our clans, our bloodline, and that way we know how we would properly introduce ourselves to Navajos that are of one of these four clans, our four mother clans. Next slide, please. My position here at ADHS, Arizona Department of Health Services, was created in 2001. It's 100% funded by general funds. I'm a one-person office, and I report to our Assistant Director, Division of Policy and Intergovernmental Affairs. Next slide, please. Here's some guidelines that I've found to work. I've been now employed here, Arizona Department of Health Services, I'm in my 21st year. If at all possible, hire tribal staff, learn some of the culture and history of tribal people, know the HIV/AIDS personnel within the tribal government, health, urban Indian health programs, and our intertribal councils. Next slide, please. Build trust, seek tribal input before the fact, keep ongoing communications, build coalitions, and be committed for the long term. I found these to work in terms of a number of partnerships that we've built here with our tribes in Arizona. Next slide, please. If you're going to work for tribes, you got to know a little bit about sovereignty. Sovereignty is sacred to Indian people because of our history. It's what we have left to manage our own affairs. So by tribal sovereignty, tribal governments are able to make their own laws. Unfortunately, there was a public law passed in Public Law 280 that gave some jurisdiction to states. So there are some states like California that have some jurisdiction on tribal lands. And tribes are subject to federal law. Next slide, please. If you're going to work for tribal people, you got to have an acknowledgement of our tribal cultures. In healthcare, we have ancient knowledge that have kept us well for centuries. We were very well, we had good health prior to Columbus, and we still have that knowledge. And our healthcare is based on being in balance with nature. And our whole tradition is based on prevention, how to keep ourselves healthy and how to be independent and care for our families. We have medicine people and we have healing ceremonies that are practiced today. And we as Native people, we can get sick in two ways. We can get sick in the Indian way and we can get sick in the non-Indian way. So if we're sick in the Indian way, we know we need to go back to our home reservation and have our healing ceremonies. Next slide, please. It's very, very important to know the history of what happened to our Indian people. Of course, in our textbooks that we read in school, they just gloss over what really happened to our people, our ancestors, the genocide, the discrimination, to strip us, our ancestors, as indigenous people, taking away our culture, understand all the health disparities that we have that are a result primarily of the clashes of culture and how our ancestors were treated and even how we're treated today. Next slide, please. Now we're in the era of self-determination. So at one point in history, the US policy was to terminate our ancestors. And now the pendulum has swung to where now it's called self-determination. A very foundational law that was passed in 1975 was the Indian Self-Determination and Educational Assistance Act. So if you're starting to work with our people, you need to understand this law or be aware of it and know that healthcare is really in a transition from federal health care management to tribal management. Prior to 1975, there was no tribal health programs as we see them today. Everything was federal. And gradually, with the exception of our traditional health and our medicine people, it was controlled by the federal government. Next slide, please. Now we're also in the era of tribal consultation, nation to nation. We have went from trying to be exterminated as a people to being recognized at the highest level of government as our right to stay, our right to have tribal governments, our right to have tribal programs. And that First tribal consultation policy was issued by President Bill Clinton, Executive Order 13175, consultation and coordination with Indian tribal governments. Next slide, please. And bringing us current, President Joe Biden sustained Executive Order 13171. So he issued a memorandum very recently at the end of January. Exact date was January 26, 2021. That went to all the heads of the federal agencies and departments requiring compliance with Executive Order 13175. So there are starting to be correspondence. I just saw one recently where OMB is scheduling tribal consultation. So more and more, this is what's going to happen. And all the federal agencies have to give a report to the White House in 90 days and do annual reports. Next slide, please. Here in Arizona, and I believe New Mexico, we may be the only two states in the nation that have tribal consultation laws. And it requires tribal consultation meetings, annual report, and a designated staff. Next slide, please. So in closing, just some additional guidance that I'd like to give to our non-Indian friends and neighbors and governments that wish to work with our tribes. Tribes are sovereign nation. Indian cultures are alive and well. Tribal governments already have programs in place. Build on those programs. Tribal governments are nation building. Next slide, please. So this is my contact information. Teach you another Navajo word. It's called ahaha. That means thank you in our Navajo language. And I do maintain a website at the Arizona Department of Health Services. And there is that website link. So again, I thank everyone for being on the call and for the hosts and this effort to end HIV among all our population. And of course, specifically our discussion with our Native people. So thank you very much.
Thank you so much, Michael. We appreciate you sharing, recommendations for working with tribal nations. So thank you for that. So now I'd like the opportunity to introduce Michael Byrd, who is a national consultant. And I want to highlight that he is a former president of the American Public Health Association and the first Native American to serve in that role. And Michael's going to provide a perspective around, what are recommendations for us and for entities in eliminating HIV among tribal communities based on the work he's done for many years and his role as former president. So Michael, I'll turn the mic over to you. Thank you.
Well, thank you and good morning. Appreciate Rick's and Michael's presentation. I think they've provided the real the data in terms of Rick's presentation, the data to have us better understand where we are. And again, with Michael's his work with the state of Arizona and the legal requirements and the laws that govern the relationship between the federal government and tribes. What I'm hoping to do this morning in the time that I have with you is, I'd like to mention a couple other things in terms of my background. I actually was the executive director of the National Native American AIDS Prevention Center, which was located in Oakland, California from 2001 to 2005. And we supported tribes nationally. We worked with American Indians, Alaska Native and Native Hawaiian communities to support them in their work with tribal entities and work closely with IHS. I also would say that I was with the Indian Health Service or did 20 years with the Indian Health Service. And I did a 12-step recovery program from that experience, and I'm doing well. That's a joke. But I just wanted to just say, I think that in terms of having a real conversation here, there's two other things I need to really reference, and that is that, you know, for those of us, and I come from Kiwa Pueblo in New Mexico, but those of us who've grown up in an environment which was challenging. My own challenging issues have been adult child of an alcoholic, a family who was significantly impacted by substance abuse in terms of family, and to some extent that continues to this day. And also an issue that makes people uncomfortable, but has to be part of the conversation, and Michael referenced this, is the reality of racism, even in this day and age, and how that impacts and has negative implications for our communities, for our health, and in fact for the nation. And those things are very real and need to be addressed in a very real way. What I wanted to do, and I'm going to sort of do something a little different, and that is that I think there's a conversation that needs to be had that is a little deeper, I think. But let's also celebrate something that really needs to be acknowledged, and that is the fact that Deb Holland, who's a Pueblo Indian woman, and who also now is the first Secretary of Interior and the first Native woman to have ever served in a presidential cabinet, just this last week assumed that role. And it's historic and significant to our communities, which have not had the opportunity to serve this nation in a position that has influence and is so significant in terms of the role that she'll play as Secretary of Interior. It also models for our community, our young women, our women in our communities, of what can be accomplished through hard work and dedication. And so I think that, you know, when again, what year is it? 2021, and it's and it's taken this long for a Native woman to have had that opportunity to serve this country. And I think that we need to really celebrate that. We need to acknowledge that. We need to embrace her, and we need to support her, because the challenges she's going to face are unlike that of anyone that has previously occupied that position. So let me just say that. And so I hope that all of you celebrate that and embrace that. I think the other thing, you know, that we need to really acknowledge and be aware of is, you know, we have, as people, as tribal people, are clearly aware of the impact that COVID has had on our communities, the Pueblos, tribes, and nations throughout this country. And it is really that what has happened this last year has so significantly adversely impacted our communities in many ways, that we really need to really look at how we're going to really deal with the consequences that will unfold after this epidemic, and once we get through this. And not to take anything away from HIV and AIDS, because and I applaud everyone who's engaged in this, but we can't, you know, obviously it has impacted everything. And in terms of sharing the significance of it, and no one should be unaware of this, but the American Indian community has the highest rates and has suffered the most significantly out of any other community of color or any population in this nation. And prior to that, pre-COVID, the mortality and the American Indians, Alaska Native, have had the highest mortality morbidity rates in this nation previously. That was pre-COVID. Now we're COVID. And so I think that we need to really, the nation really, and we need to recognize what that means for our communities, for our populations, and just the implications all of that have for our communities, and that it will impact us adversely. I think the other thing I just wanted to just mention is that they, as Michael had said, that what we're dealing with really is a history of being marginalized, a history of being made invisible. There was a study that was done that the Kellogg Foundation funded that indicated that 40% of the people in this country don't even realize that there are still Native people here today. And so I think two things I'm going to just say before I wrap this up is that what we need to do is really create, we have an opportunity because this nation is confronted with real issues. There's an opportunity, and we're getting some new attention, new focus. We need to ensure that everyone recognizes that, number one, Indian people are still here. We have rights. We intend to exercise those rights, and we need to make the most of this rising tide that hopefully will raise everyone's boats and ensure that we have a future in this nation. The other point I'll just wrap up by saying is that we need to really reach out beyond those entities, just the tribal entities, we need to reach out and join and engage the national community. And I would welcome you to consider looking and exploring opportunities with the American Public Health Association, which I'm past president. This is actually my 20-year anniversary as the first American Indian to have ever served in that position. We have an American Indian, Alaska Native Hawaiian caucus, which is representative of all of our populations, which is very active and engaged. And I would encourage you to reach out to us and consider joining the caucus. And I'm more than happy to provide contact information. I'm also more than happy to provide any sort of support and encouragement and in terms of the work that you're doing. What you're doing is critical, it's important, and I thank you for the service, and I thank you, OASH and CHPTS, for this opportunity to be part of this conversation. Thank you.
Michael, thank you so much for your wise words, and so important. You know, this is bigger than HIV when we talk about inequalities, right? And COVID has really lifted an additional window to the inequalities that our communities are facing. So thank you. And I'm hoping to have these discussions during our discussion session. So I appreciate those wise words. So now what I'd like to do is, you've heard from 3 of our leaders across the nation on some of the strategies and some of the disparities that our Native community are facing. Now I'd like the opportunity to give the rest of our panelists an opportunity to introduce themselves and share some of the work they're doing around their organization. And then we're going to have a discussion, continue talking about what Michael Byrd and Michael Allison have introduced to us. So the first panelist I'd like to introduce while I load up her slides are Savannah Jean. Savannah serves as the Program Director for Community Health Education and Resilience Program, and she is a National Native HIV Network Administrator. So Savannah, if you give me 1 second, I think I'm gonna be able to load your slides. Can you see it? Is that good?
Yes, thank you, Michelle.
Okay, awesome. So I'll turn it over to you now.
I just want to first thank Michelle and everyone at UCLA for coordinating this event today in honor of National Native HIV/AIDS Awareness Day. My name is Savannah Jean, and I work with the Albuquerque Area Indian Health Board as the Program Director, as Michelle mentioned, and also the administrator of the National Native HIV Network. And we're going to be sharing some of what we've been doing with the National Native HIV Network over the last several years. So, but before I start off on that, for my Navajo relatives and other relatives that I have, Che Savannah Jean Inishia, Kutsoni Nishlo, Ishka Ansaho Bashashin, Katnasan Hidashiche, Dog is a Lana Dashnala, Ayese Nadan Ile Nasha. So just for grounding, I want to introduce myself to my relatives. I come to you from Albuquerque, New Mexico, on the lens of our Pueblo relatives. And so the National Native HIV Network was started with the in-kind work of these individuals: Hannah Blue from JSI, Kurt Begay, who is our capacity building specialist at the health board, myself, Elton Noswood, who is a consultant, and then Ann White, who is our executive director of the Albuquerque Area Indian Health Board. In 2016, and even prior to that, we started to have discussions about the need for a national organization that brought together individuals working within the field of HIV to really partner with one another and begin to strategize how we can start to address the HIV epidemic within our tribal communities, especially seeing that, because our numbers can be quite small compared to other racial and ethnic groups, we find that American Indian and Alaskan Native people are not a priority population often. And so we wanted to find a way to bring people together so that we can begin to coordinate our efforts and also coordinate other national events. So if you go to the next slide, please. We began this process formally during several different events. In 2015 and 2016, we had the Southwest Hepatitis C Tribal Summit here in Albuquerque. And then we followed that with other events that brought together HIV service providers and began to really do this participatory process in looking at what are things that we need to ensure the successful implementation of a network like ours. And you see here the picture from the United States Conference on AIDS, which is now the United States Conference on HIV and AIDS. We brought together many of our partners to start to look at these steps that needed to happen. And as we began to formalize the process, we're happy to see that a lot of those things that we strategized in 2016 are coming to fruition now. Next slide, please. Beginning in 2019, we were fortunate to receive funds through the Minority HIV/AIDS Fund through the IHS National HIV and HCV program to formalize this network. We were enabled to enhance the membership to include regional representatives from the areas seen here in the map. And this was really a way for us to have regional reps come together. We have bi-monthly meetings to discuss awareness days, also to plan around HIV, STI, and HCV testing, prevention, and treatment, and also including our harm reduction strategies. Next slide, please. These are the regional representatives that are currently serving now for each of the different regions. We do currently have a vacancy for our Northern Plains region. So if you know of anyone or you are from that region, we welcome you to reach out to us here today or by email. But we're very grateful for all of these individuals and the input and the work that they have done over the last year in this formal process of the National Native HIV Network. Next slide, please. And again, I am the administrator for the National HIV Network. Kurt Begay is a co-coordinator along with Elton Noswood. Next slide, please. In February 2020, prior to the pandemic starting, we were able to have an in-person meeting in Anchorage, Alaska. The Alaska Native Tribal Health Consortium hosted our first meeting of our regional representatives. A majority of our regional reps are pictured here. And during this time, we were able to plan for the upcoming NHAD in 2020. And since this structure had just been formalized, we got a little bit of a late start on that last NHAD from 2020. And at this time, we were also able to talk about, what is going to be the role of the regional reps within each of their different regions. What do we want the network to look like, and what is going to be our purpose and mission? And we're very happy to include our Native Hawaiian relatives, because we really feel like, NHAD also includes that population. And since they do not have the same sovereignty rights as American and Alaska Native people, we wanted to be inclusive of them and ensure that they had the advocacy here within the network. Next slide, please. This year, on World AIDS Day, we launched our website. You can find it at nnation.org. Here on the website, we have information about us. We also have, we are collecting information about service providers across the nation. So if you have not filled that out, we would love if you could participate in that. Here on the website, you see a link at the top that says Service Provider Directory. That'll link you to a survey for collecting your information. We also have a members tab, and under that you can submit a form to become a member of the National Native HIV Network and also subscribe to our newsletter. We also host the project through MAIF as well, Our Story. The links there are for a timeline that looks at HIV prevention and treatment within tribal communities and Indigenous communities as well. So we encourage you to take a look at our website. Next slide, please. We also have a monthly newsletter that goes out, and then a mid-month newsletter that provides updates. You can, again, subscribe on our website at this link on the bottom. We've been able to have highlights on our regional members, also providing information on upcoming events and awareness days. Next slide. Since the start of the pandemic, we've hosted monthly webinars on various different topics. These webinar recordings are available on YouTube. In April, we will have a webinar on stigma that will feature presentations from our partners at the UI-HI, and then also through NMAC, the Escalate program. So we're really excited for that. Our last webinar was on the NHAD and talked about the history with some of the founding members of the National Native HIV/AIDS Awareness Day. Next slide, please. You can view again the webinars on our YouTube page. We also host the videos that were created through the MAIF funds on PrEP and providing that education. So those can be shared from our YouTube page. Next slide, please. And we've been very happy to coordinate the National Native HIV/AIDS Awareness Day. The theme is something that our regional membership comes together and we create that together. We also review any of the content that goes out together and look at what images we want to go into the products as well. The poster here was created by Jolene Yazzie, the graphic designer that we work with. And the picture there in the middle is a picture from the Circle of Harmony HIV/AIDS Wellness Conference that happened in 2019. And then the sweetgrass, or also braids in our Native Hawaiian cultures and basket weaving. That is a symbol that we've really incorporated into our logo as well. That talks about, coming together and the strength that we have in that when we do come together. And so that is reflected in our theme this year. Next slide, please. So please follow us on the National Native HIV Network social media pages. We have an Instagram and Facebook and a Twitter account at Native HIV. Again, this work is supported by the Minority HIV/AIDS Fund.
Thank you so much, Savannah. I know there are some questions in the chat box, but we're going to wait until we give all of our panelists an opportunity to introduce themselves. So now I'd like the opportunity to pass the mic over to Travis Lane, who is the Assistant Director for the Intertribal Council of Arizona. So Travis, the mic is yours.
Okay, thank you, Michelle. And thank you for inviting me to this event. The National Native HIV/AIDS Awareness Day is an event in which we celebrate life and the promotion of how we continue to be a person of well-being and of health. And we don't necessarily commemorate those who have passed, but we certainly celebrate those who continue to live and continue to make choices for their well-being. And so I really appreciate this opportunity to be a part of this event. I live in the Phoenix Valley, so I'd like to do a land acknowledgement. The indigenous peoples of the Akimel and Peepash peoples have lived and inhabited this area since time immemorial. And I want to thank them because of their knowledge of the earth and the management of the earth. That is the reason why I'm able to live here in the valley. My work in HIV/AIDS prevention is pretty limited. I worked on a teen pregnancy prevention, HIV/AIDS prevention grant a couple of years ago. My mentor in learning that work was Gwenda Gorman, which many of you may know. She has since moved on from ITCA to do other work back in the Navajo Nation, but she was definitely one of those individuals who was an advocate for why it's important that we address these issues in tribal communities. She was the one that taught me correct condom use. I will say that the first time I ever did a demonstration like that, I had the hardest time saying penis. Penis and vagina. I stuttered on that one. And many of you who are on this Zoom meeting probably are very aware of the education outreach that we do in this work and how important it is. And you guys are probably more of the experts about this work than myself. But we did want to, I did want to just give you a quick brief overview about the work that we're doing at Intertribal Council and how we're supporting our member tribes. There was a really so the prior executive directors of ITCA had once told me that it was controversial for ITCA back in the 90s to accept money to even talk about HIV/AIDS. And the leadership, the past executive leadership made the decision that this is going to be a real issue in our tribal communities, and we need to talk about this. So it was very controversial for us to accept federal funds to talk about HIV/AIDS back in the 90s. And I think that really is the beginnings of what stigma looks like in our tribal communities, that we don't even want to talk about it. And ITCA has been working on HIV/AIDS work since the 90s up until now. It's gone in different forms. Of course, it's always dependent on federal funding. And we all know that that's a limited resource for our communities. When Obama and Trump prioritized the areas in which we needed to focus HIV/AIDS prevention work, tribal communities were not a priority, unfortunately. But we have, and in that work in the 90s with HIV/AIDS, it really did came down to the need for capacity building around HIV/AIDS prevention and around stigma. That we need to really work on stigma because people are so afraid to talk about it that they're not even willing to want to get tested on it. In the IHS and tribal health facilities, American Indian women who are pregnant are offered the test, but oftentimes they don't agree to get the test when they're pregnant, and that's an issue. There's no standard. There's no standard of care around HIV testing for men or men who identify that have sex with other men. And so there needs to be some standards of care around that as well. And so ITCA is really looking at HIV/AIDS in a policy perspective of how we can just do some very simple prevention and treatment. We're very happy that PrEP is an opportunity in which people can stay safe, but it may be not acquired or accessible in very rural communities like Arizona. Because I think this is probably something that I'm personally very proud of, is the healthynativeyouth.org. This is a website out of the Northwest Portland Indian Health Board. They've been a great partner for so many years. We're promoting evidence-based curricula that addresses teen pregnancy and HIV/AIDS and STI prevention. And it's very probably really appropriate now because we're in this pandemic. It's all online. All these curricula are online. So your schools and community-based organizations could utilize this resource. And ITCA, if you are located in Arizona, Nevada, or Utah, we can provide you some resources to prevent or to implement these programs in your communities. And thank you, Asia, for putting that on the website. As many of the other intertribal organizations throughout the nation, we also are a recipient of the Ending HIV Epidemic Funding. And again, we have a great partner, Alaskan Native Tribal Health Consortium, really is just a leader in HIV/AIDS prevention up in Alaska. And so we just copied them, re-replicating their work. And so they have a great program called I Want the Kit, which is an online program in which you can get an anonymous HIV/AIDS testing kit mailed to you. I think it's a swab that you do, and then you send it back, and then they give you the results, and then refer you to any sort of local health center. So, yes. I think the idea around best practices about really celebrating all of your work that you do is really us working together as a coalition, sharing what works, what doesn't work, and then being that advocate. We need to be advocates around HIV/AIDS prevention. If you're not advocates, then we're not helping our own cause. And that's what this day, National HIV/AIDS Awareness Day, is all about. It's about celebration of life and the advocacy that we need to address this issue. Thank you.
Travis, thank you so much for that and sharing all the great work that ITCA is doing, not only in Arizona, but across different states. So with that, I'd like to pass the mic over to Hannah Youngdeer, who's the Public Health Program Coordinator for the California Consortium for Urban Indian Health, to talk about some of the work they're doing around HIV to support Native communities in California.
Thank you. And thank you all for, inviting me to be here. Very happy to be here and share what I know, but I just want to thank all the people, and I see Elton in the chat, who have gone before me and done this work and really, have taught me through their work to teach me how to do this work as well. So just wanted to mention that real quick. As Michelle mentioned, I am a public health program coordinator for the California Consortium for Urban Indian Health. A little bit about our program. We are a small nonprofit in California, and we work with the 10 urban Indian health programs throughout the state of California. We provide TA for numerous public health program initiatives, all of which I won't be able to get through today. But I'll just highlight 3 that we're working on to address HIV and AIDS and also Hep C. So the first one is the project that I'm over, is our Tribal Medication Assisted Treatment Expansion Project. And through this initiative, we do a lot of different things. One of those is a materials campaign where we educate the community on opioids and substance use and using safely. A lot of harm reduction practices and naloxone distribution goes into that materials distribution education program. One of the other things that we do and are starting this year is a California Indian harm reduction work group. So that's new this year, and one of our main initiatives is to create a network of harm reduction workers throughout the state of California who work in our tribal communities, whether that be in our urban communities or in our rural communities, to educate and to network and bring out best practices within our group, and kind of go over what harm reduction is looking like in the California Indian community right now. And then the other initiative that we work on in the TMAT expansion project is the California Indian Opioid Safety Coalition. And we offer quarterly meetings for anybody in California who are interested in working in our American Indian Alaska Native communities, for our tribes or urban Indian health programs, come together as a coalition and share best practices, network. And we also provide educational trainings during that. And we also just provide a lot of educational opportunities as well. The other project that Sakui is working on right now is called the Getting Real About Stigma Prevention, or GRASP for short. And so this is a stigma prevention program for Hep C. We also include HIV and AIDS work in this as well. One of the first things we're working on is a stigma reduction campaign, and that is very similar to our materials campaign for our TMAT expansion project, creating materials and getting them out to our communities to educate people and to attempt to reduce the stigma that is really, really prevalent in our communities right now. The other thing that the GRASP program is working on is to review the Urban Indian Health Program HCV testing and treatment services. Kind of like Rick had mentioned earlier with the report cards, so that we can work with our Urban Indian Health programs to see what their HCV services look like, and to make recommendations and to really work with them to amp their services in that realm. The other thing that we're working on is a community perception surveys to really see what stigma is looking like in our communities. These surveys will also allow us the opportunity to create materials that can tailor to some of that stigma that might be in our communities right now. And then we're also working on a new initiative at Sakui with the Office of AIDS. I see Angie is here, and I believe Kevin is here with the Office of AIDS. It's good to hear from you all. We're working on a new initiative with that office to lay out what the HIV services are looking like in California right now for our American Indian Alaska Native communities, and to see what kind of services it is we need, what are we missing. And then also within that initiative, we'll be creating a strategic plan to move forward and to address a lot of those things. That's all I got. So Michelle, thank you.
Oh, can you hear me okay? Okay, perfect. I said thank you so much, Hannah. So thank you to all the presenters and the panelists for providing some great information. So now what I'd like to do is I'd like to follow up on some of the things that some of our presenters and panelists touched on. We heard a lot about stigma, historical trauma, the history and racism. So I'd like to invite all of our panelists and our presenters to join us back in the room virtually. Turn on your cameras, don't be shy, and just have a conversation. So for the next 10 minutes, I'd just like for us to unpack a little bit more what we heard and then open it up for questions and answers. So I'm going to start with the first question. We heard a lot in the beginning about some of those challenges that our Native communities are facing that really impact opportunities around HIV education, testing and treatment, and accessing prevention services. So I want to start asking Savannah, what do you think are some challenges that our Native community continues to face around these three areas when we talk about testing, treatment, and services? And how does history and some of the culture factors that were talked about really impact and amplify some of those challenges based on the work that you're all doing, not only locally, but nationally?
Thank you, Michelle. I think there is, if we look at the data and some of the challenges that the panelists talked about, the racism, looking at stigma, a lot of it, I think, is rooted within colonization and the historical and intergenerational trauma that many of our communities face. You know, there is the related factors such as substance use, the mistrust of medical professionals that we've seen because of things like forced sterilization. Also, you know, I think there has been research noting that people of color often do not receive the same level of medical care because they are people of color. And then there is something around the work that's been done around Indigenous data sovereignty. The data that comes out is for communities and it is done by communities. But when we look at the data that is collected, oftentimes, you know, because the numbers can be so small, we are left out of conversations, we are left out of initiatives. And so that has huge impacts on the funding that our communities do receive in order to provide HIV testing and prevention services in our communities. And then I think even with stigma, that is also related to colonization. You know, prior to colonization, our communities had their own ways of thinking about sexuality and gender identity. You know, we have our Two-Spirit community as well. And a lot of those things we have seen within our cultural histories. And with colonization, this idea that sex is only between a man and a woman and is only for procreation is something that deeply impacts our communities and how they access any of those services for HIV testing, treatment even. And so I think, you know, knowing that history of colonization is really important for providers that are working within tribal communities and being willing to make those long-term commitments, as one of our panelists mentioned, because, you know, it's not just an email that's sent one time. It is a built relationship that happens over time, you know, emails, phone calls, and then a visit, hopefully when you know, the pandemic is under control, we can start to build that.
Thank you so much, Savannah. You know, so important, some of the key things you mentioned. And that leads me to a follow-up question. You know, we have on the panelists here, you all are working both in urban and rural communities, right? And Hannah, a question for you. Here in California, we know that about 90% of natives reside in urban areas. Based on the work you've been doing to support some of the urban clinics in California, do you think there's some challenges that are unique or different to those living births, both in urban and rural settings?
Yeah, there's definitely some, and I just want to, I think this question also ties into that historical issue, right? We know that the removal of our tribal populations into urban areas was a method used by our government. And I just want to say, unfortunately, it's working. I think a lot of our people in our urban areas, you know, are lacking that cultural connection, that form of identity, and, you know, trying to find their roots back to their tribal people. So I think that is one of the issues that we do face. And then at the same time, you know, there's a lot of tribes that come together in one area. So you have a lot of traditional practices all in one spot. And so I think, you know, I think all of my Native brothers and sisters know I mean when I say there's lateral oppression that can happen because of that. Who's teaching the right ways of traditional medicine? Who's, you know, saying the right words? So I think we have that issue too. I think one of the other things that we face, and this is less of a cultural issue and more of a data issue, is that we do have a lot of people who will come from the rural areas to the urban centers to get treatment because of that stigma issue and because of the anonymity that being in a new area can offer somebody who might be scared of facing stigma, scared of seeing their auntie at the health center, you know, in their tribal area. And so I think we also see that a lot. But within that happening in the movement of people coming for treatment services is that we lose a lot of our patients and our numbers and our connection. And so I think a lot of the times it can lead to that low number that we often see that leads us to not get as much funding for things, not as get as much support for the HIV work in our communities.
Thank you so much, Hannah, for that. You know, when we talk about, you know, Natives living in rural and urban areas, we also know that Natives are culturally diverse, right? With over 574 federally recognized tribes, many of them sharing different languages, cultures, beliefs, and practices. You know, what are some of those things, or how does traditional value and culture play in helping to overcome some of the stigma, the historical trauma that we mentioned? I wanted to ask Rick, maybe starting with Rick, based on the work he's done nationally, and I know some of the programs have really focused on enhancing some of the traditional values around culture for prevention.
Thanks, Michelle, and thanks, Savannah and Hannah, for your good words. I wish I could speak as eloquently as you all do. But at the core of all we do are our people, and the core of our people is their culture. Without learning from them, knowing what works for them, we fail. And it's been proven, I think, time and time again. If we don't go to our communities and ask those who live there, who have lived there for generations, what their teachings were from many, many, many generations ago, then we're not going to be successful. Everything we do must be based on the understanding that culture comes first. Now, oftentimes, of course, Western medicine conflicts with culture, but try as we might, we do at the Indian Health Service try to work with tribes, with urbans, with other Indian organizations to help better understand the culture. And it's kind of a shame, right, that we are limited so often in the types of funding we can put out. It's based on numbers. Well, if you can't prove you have a certain diagnosis rate, then we can't give you any funding. But why is having 10 cases of HIV a community at a higher priority than someone who has one case? Isn't that one case just as important? So I think we have to understand that the we that we serve, all of us, the collective we, is so important. Every single bit of that has a purpose, has a meaning, has a cause and effect. It's the spider web that we try to have that perfect balance, that perfect harmony, vibrations through that web of programming, of data, of input from our communities. It's all important. So I am always trying to make sure that people at the decision level making seats in HHS understand that. And I think this is getting better. I think our advocacy work for the years has really done a good job. And I think all the folks on the call here and organizations around the country who have stressed that for a very long time. So I just really want to say that culture is very important. And we do take that in stride with everything that we do.
Thank you so much, Rick, for that. Absolutely, culture is important in many communities. I wanted to give an opportunity to Michael Byrd to talk about his work, to give comment around culture and some of the stigma and historical concepts that we've talked about in your work with APHA and the tribal group. What are some recommendations or some things you have around implementing culturally sensitive interventions for our Native community?
Well, I think first of all, if one really wants to understand what has happened to, if we want to understand and people who of good faith and good inspiration want to really understand what where Native people are today, having the worst health disparities, having the worst mortality and morbidity rates, one has to go back into history and really understand what happened to Native people. And that history is challenging. It's predicated on genocide and the removal and theft of Indian land and the ongoing oppression of Native people. If you were to take any community, any population, you were to subject them to the same things that Native people have experienced historically, you would see the same sort of negative implications and ramifications of that oppression. I believe that we're moving, we have an opportunity to move in a new direction in a new way. And it's predicated on Black Lives Matter. It's predicated on a real awakening of the fact that things have to change in this country. And I would say that if we can't get it right with Native people in this country, it's never going to happen anywhere in the world. And one positive, there is a positive sign, because I talk about this stuff, it seems so burdensome in so many ways and so negative, but the Biden administration, in addition with the executive order requiring tribal consultation, the Biden administration has made $3.2 billion available to tribes. I mean, and that's historic. There's never been that level of funding made available to tribes in the history of this country. And so I think it's a step in the right direction, but there's a lot more that needs to happen for our communities. And I guess I would say, again, if we're going to change things that deal with all of the things that impact our Native communities, be it HIV and AIDS, be it our significant mortality rates and morbidity rates, we really have to come together as community, as individuals and communities, and support each other and rise up and make our needs and our voice known. And we need to coalesce with other communities, all of the other communities across this country, and particularly those that have been historically oppressed. One of the things that I just have to say this very quickly. One of the things that's so significant is there's a lot of discussion about slavery being, the first moral sin of this nation. And I would say, yes, it is a moral sin. It's abhorrent, it's inexcusable, but that was not the first moral sin of this nation. When you talk about this nation and the history of this nation, you have to start at the beginning. The beginning starts with Native people who weren't discovered in 1492. We discovered somebody who was a boat person that was lost, and we discovered them. They didn't discover us. And that also fails to acknowledge the fact that we've been here for 10, 20, 30,000 years longer. And so when you talk about anything about this nation, I beg to say you have to start at the beginning. And the beginning of this nation starts with Native people. And until we have an honest historical conversation and get it straight and get it right this time, it's not going to change. And so I would, and that requires us taking on, again, stepping out, engaging the larger community, and educating them to the true history of this nation, because it all starts with Native people. People may not want to acknowledge that, people may not know that, but we know that, and we have to step up and engage the larger community and correct the fallacies and the misinformation and the lack of information that exists when it comes to Native communities. And I include clearly Alaska Natives and Native Hawaiians, because if you want to talk about a population whose history you don't hear about, is totally ignored and minimized, it is Native Hawaiians.
Michael, so powerful words. Thank you so much. And this leads me to our closing remarks when we talk about a call for action, right? I wanted to just give each of our panelists maybe 30 seconds, less than a minute, to just tell us in a sentence, like Michael said, what what is our call of actions as far as moving forward? So I'm going to start with Hannah for closing remarks. What are recommendations for call of actions for us?
Okay, real quick then. One thing that came to my mind is that, you know, our tribal communities and our urban Indian populations, we know the answers, right? We know what we need, and we know what our communities need. We've been doing this for years. We've been taking care of ourselves for years. And what we need is allies in that work. We need support. And we need people that will come in and ask us, you know, and come in and get to know us, what it is, what do you need? How can we help you? And how can we work together to achieve these things? So my call to action is just for that communication to happen, that collaboration.
Thank you, Hannah. Savannah, final words.
I think one of the things that would be really important within Native communities is continuing to come together and build that collaborations within our communities, and really trying to do away with those colonized borders that have been imposed on us. You know, we can't work in silos. We really have to come together and do away with those borders, because, you know, all of our communities need us. Thank you.
Thank you, Savannah. Travis?
So INHAD is all about the celebration of life. And so I want to thank everyone who was on participating in this Zoom call. I celebrate you. I celebrate your choices for you to be a well person, especially in this time of COVID. And we really just need to come from a more of a positive perspective of how we address this issue, and not this deficit perspective. Because celebration, that's what this day is all about. It's about the celebration of life. So thank you so much for this opportunity.
Beautiful, we say thank you. Rick, any final call to action?
Yeah, I think the call to action is talk about HIV, eliminate stigma, get people you know into being tested, because if we get folks knowledge about their status, get them into care, keep them there, they have a 0% chance of passing along the virus. And those people who are at risk for HIV, talk about PrEP. Get folks into PrEP. If you take PrEP, one pill once a day, you're 99% sure that you're not going to acquire HIV through sexual contact. We have the tools and the ability, the knowledge and the talent. And as you've seen today, we've got a lot of know-how, a lot of cultural grounding, and we really can get to the goals of EHE by 2030. And that's a reduction of new HIV diagnosis, cut it to 90%, cut it by 90%. I think we can get to zero. The theme of NNHAAD, getting to zero.
And then Michael, last final words, Michael Allison, for our call of action before we close. Michael, you're on mute.
Darn, I was just giving my best speech. Well, I want to thank everyone for being on the call, and for all the great work, and for all the commitment. And I think everybody said it all. You know, we just need to reach out. We need to get to know one another, and support what the tribes are already doing. And I think as service providers, just reaching out, finding out that information, and then seeing how we can support the tribes and urban programs, and run our programs accordingly, and encourage our leadership to also take that position as far as service providers to the tribes. And just keep communicating with one another, because there's power in working together and combining all our knowledge for the betterment of our people. So thank you.
Well, I know that we're at 12:31. I just want to really thank all of our panelists so much for sharing your amazing work and amazing wisdom with us. I feel like I learned so much during this session, and we're hearing that from our participants in the chat as well. And we really hope that this session ultimately can inspire more action. So we really, that's really what the purpose of this session was. And we hope that participants kind of took away these amazing recommendations and can really, you know, apply what we talked about in their own work and in all of our work together. I also just want to remind folks to please look out for an email after the session. We'll be sending an evaluation link and also some relevant resources. And we just really look forward to continuing these conversations with you. So on behalf of both PACE and UCLA CHIPTS, thank you so much and have a great afternoon.